My name's Nichole. This is Fliss. So today we are going to do a case-based presentation on a patient that was primarily an ECC patient in our ICU. We get a lot of cases from other departments in the hospital, ECC, medicine, oncology, that come through our surgery department. Our department is busy. We have a fast-paced environment that enables us to achieve many interesting and exciting skills and procedures. A little bit of a closer look at what we do day to day is, for example, all patients requiring sedation and anaesthesia, our team are responsible for, alongside the anaesthesia clinicians, residents and interns. We start our day generally preparing and setting up our rooms in preparation for patients to go through them. We get all the equipment ready, anaesthesia machines, things like that. We then, our next stage tends to be we prepare the patient plans. So we read the history, we look at the blood results, anything that might be relevant to that case and patient that day. We then speak to the anaesthesia clinician about the case. We have a chat through about what procedure is going to happen, the history of that patient, in order for us to get an anaesthetic plan. They generally will tell us what they want to do, and we'll have a chat about it and go from there. Other things that we do as well are assist with local anaesthesia, nerve blocks, and epidurals, things like that. We also assist patient workflow. So we communicate with other members of our team, other members of different departments, to help workflow throughout the hospital. Alongside the setup of the day, we set up our theatre suites to include preparing kit for different surgical procedures. We get everything ready on a trolley in the morning, just so that we can be as efficient as possible. So a little bit about our patient that we're going to talk about today. He's called Chunk. He is a 1-year-old male entire large crossbreed. He came through our ECC department with a history of a week of lethargy, inappetence and severe weight loss. He lost 10 kilos in a month. He'd been to his referring vets and had some treatment with them, but slowly started developing other symptoms like dyspnea, and he became non-ambulatory, very lethargic. So then he was referred to our ECC department. He had no other relevant history before this, so this was his first kind of medical issue. So what was wrong? So ECC obviously seen him in and conducted his first lot of tests and clinical exams. So the first thing that they'll do is kind of like a POCUS, TFAST, and they found he had a severe pleural effusion. They did tap the fluid, which showed to be a pyothorax, so that's pus in the chest. They did some baseline bloods, so we did a PCV and total solids. This is good to have as a baseline for any patient really that's going through anaesthesia, but especially for older patients or patients that have underlying problems. On his blood gas, you can see highlighted is his lactate. He was quite severely hyperlactemia at 8.1. This most likely in his case was due to a decreased tissue perfusion. So probably the result from this was his hypertension, so he was quite severely hypertensive on admit. Before going into an anaesthetic or surgery or imaging procedure, it's a good idea to stabilise these patients first. So that's treating his low blood pressure with fluids, vasopressors if needed. So a drug that will kind of shrink his vessels and bring his blood pressure up. And so while he was in the ICU, they did treat this, and his lactate did slowly start coming down till we were at a point that we were happy to anaesthetise him. So on the day of his admit, he did have a CT. This was to see kind of what was going on with him. And unfortunately on that day, his CT was inconclusive because of his severe pleural effusion. So it was difficult to assess his lungs, assess if there was an underlying reason. He did unfortunately decompensate both during and on recovery of his anaesthesia. He was hypoxemic throughout, with an SpO2 of around 88%, and he was on 100% O2. He was also quite severely hypocapnic as well, with a CO2 of 60 to 80. This was with ventilation as well. And alongside that, tachycardia, 170 to 180, trying to compensate for the issues that he had going on. At this point, the decision was, on recovery, was to re-intubate him and mechanically ventilate him overnight. This was just to try and give his lungs a bit of chance to recuperate, stabilise him a bit better, try and get some more of the effusion off. The effusion was proven to be quite difficult to drain, and it was really, really thick and purulent, and they were really struggling to get much off. So the plan was overnight to ventilate him, try and get more off his chest, provide some relief from him. Obviously it's quite exhausting if they're trying to breathe and their lungs aren't doing what they should. And then improve, basically get him a bit more stable before we would repeat the CT and he would probably have surgery the next day. So some things that we would need to consider for these kind of patients, every patient really, but specifically critical patients. So ventilation. So Chunk already was on the ventilator from the previous night in ICU. So with him, we just had to think of the logistics of swapping him over onto our surgical ventilator. The ventilator that they're on in ICU is a bit more of a long-term ventilator, so it's used slightly different. So we would move him onto our anaesthetic machine. So we just had to use an AMI bag when we moved him. Made sure that, so he was going to CT, so we had to make sure that the machine was set up, ready, all the settings were ready to go, so that we can literally just swap it 2 to 2. So rather than leaving him in between and the risk of him decompensating again. And then ventilation itself during, we go off a standard 10 to 15 mils per kilo of volume. This is a bit variant depending on disease, size of dog and things like that, but that's our baseline that we go from. And then pressure control versus volume control. So you can choose to put a certain amount of volume through your ventilation, or you can set a pressure. Now with these kind of cases, sometimes volume can cause a too high of a pressure because the lung is really consolidated, really collapsed. If you put a certain amount into that lung that it physically can't expand to, then you can have a too high pressure in the chest. So for this case, a pressure control is better because we can set the pressure that is going into the chest and we can manage it from there. Hemorrhage is always a risk for any surgery. So we have to keep in mind that he may lose some blood. So things we need to think of is during, if he does have surgery, then how much blood he's losing. So he may lose that through suction as it's being suctioned out of him, so we need to monitor the pots. Also swabs, we need to weigh and calculate the blood loss from the swabs as well. We do that as we go through the surgery and keep an eye on the volume. We work out the volume beforehand, what the blood loss is, and we make decisions with the anaesthesia clinicians based on if we need to do anything about it. The other thing we should think about as well is, depending on the surgery and the patient, we may blood type beforehand, or if not, we have it in our mind to be ready to blood type, so know what blood tube to get and have the lab on standby ready to blood type for us. We do keep dog blood in stock, so we can always give it if we need to. Another consideration is arrhythmias, so very common during any surgery in the thorax. This is because any big vessels in there, the vena cava or the heart, can be manipulated and even occluded during the surgery itself. They have to move things out of the way to be able to see what they're doing. So generally, if you do get arrhythmias during an open chest surgery, they're quite self-limiting. They don't generally require treatment because usually once there's, the fiddling has stopped, then generally you won't get the arrhythmias continuing. If they do cause a problem, so the arrhythmias continue, it affects the blood pressure, then we can treat them, usually with lidocaine, although not in cats because it's toxic to cats. Regurgitation. So this is something that we think about for all of our anaesthesia patients. We, a lot of the time, will preemptively treat for re-gauge. Big dogs especially, any cases that may be turned quite a lot, especially orthopedics, they're going from x-ray to theatre to x-ray. And we may treat with meropitant, omeprazole, things like that. Nociception. So it's every patient going through surgery or any kind of stimulative procedure we have to think about. There's various options for us to use. We can use CRIs of dexmedetomidine, fentanyl, ketamine. Particularly in Chunk, he was already on a dexmedetomidine CRI. So we continued that during his CT, and he did eventually go for surgery. When he went to surgery, we used boluses of fentanyl. We could have used CRIs if needed, but I'll get to that a bit later. A lot of this is clinician dependent. So, some people have certain preferences over others. It's all about having a chat. Local anaesthesia-wise, we didn't do a block in Chunk because we were worried about his stability under anaesthesia, and also the severity of his effusion would have made a block difficult. But we can do other kind of blocks, which Fliss will speak about a bit later. Hypoxemia is another consideration, which we already knew that Chunk was struggling with. So the most important thing is to give 100% O2 if they are becoming hypoxemic. So generally below 95%, we should probably do something about it. Under 90% is considered severe. If during surgery or even on CT, the lungs look like they're struggling, they're collapsed, they don't look like they're ventilating very well, we can do something called recruiting. So usually this is done manually rather than mechanically. So it's just something that will expand the lungs a little bit and try and get some oxygen through there. Another thing to combat it is PEEP, so positive end expiratory pressure. This is something that will keep the airway pressure above atmospheric level. So basically when they take an inspiration and an expiration, the expiration will be a bit bigger than what it would be with a natural breath. So it's just to keep that airway open. This is just a quick brief look at his anaesthetic chart. So it's maybe not as complete as what others will be, but this is because he was already under a very deep sedation and already on his CRIs that he was on, and then moved through to us asleep. So, but yeah, you can see how we fill them out, what we go through, what checks we do, about us chatting to the clinician, and the history and the bloods, and we kind of chat through all of it, and that's how we make our plan. So the next day, he had a repeat anaesthesia for another CT. The findings of that were bilateral pleural effusion, and they did see on the CT a small cystic lesion in one of the lung lobes, which they suspected could have been something called a bulla, which is an air pocket. So from that point they suggested investigative surgery, so we got consent from his carer and he came to surgery. So this is his CT. So the little arrows point to the little cystic lesion on all of the above. And then on this one specifically you can see his effusion and how it's causing the lung to be compressed and squished upwards. What else do we need to think about in these cases? So anything critical, we should think about access. So central venous catheters are something that we quite commonly do in critical patients. They are suitable for longer term use, so if we think that they're going to be in the hospital for a prolonged period of time, then we know that we can have that access. Also, along the same lines of a critical patient is total parenteral nutrition. So it's very useful if you have a central venous catheter, if they do need to go onto that post-operatively. You get more accurate blood draws, so your blood gases are more accurate. And specifically for Chunk, he had peripheral edema, so his peripheral IV access was very difficult to obtain and to keep. So that was the reason why we chose for him to have to have one. An arterial catheter we place in a lot of our patients. It's a really good way of getting more accurate blood pressure readings. So we do invasive blood pressure monitoring. So on the bottom you can see the arterial pulse, and the blood pressure is obviously more accurate per pulse, and it should match with your ECG. Each pulse should match. And then we also get arterial blood gas, which again are much more accurate.
Hi everybody. So I'm just going to talk a bit about the actual surgical procedure itself. From clipping and prepping, I don't know how many of you guys do thoracic surgeries in practice. With us we do quite extensive clips, so talking to the carers beforehand, clinicians will have a chat to them and say, your animal's going to be quite bare once we finish clipping them. But you can see from this image, we've clipped from sort of the bottom of the jaw all the way down to between the groin area, and then laterally quite far down as well. The reason behind this is because we want to keep sterility. It helps with draping. The clinician will drape kind of from here all the way down, and what we're going to be doing is making an incision along the sort of breastbone anyway. They'll drape a little bit further down the side for afterwards when we place chest drains for recovery. We predominantly use Hibi like most people, 50-50. With these cases, they particularly get cold quite quickly. We normally have like bare blankets blowing underneath, as well, to try and keep them as warm as possible, wrap their fluid lines, and try and keep them as covered as possible. Once we've obviously clipped and prepped, we hoover, lint roll, try and remove gross contaminants, take Inco sheets out, replace Inco sheets. This will be the stage where arterial lines, central lines are placed. I'm sort of the person who does quite a lot of the clipping and prepping, so my first thing is clipping the neck and legs for art lines and central lines. And while they're then placing, I'm clipping the rest of the animal as quickly as possible, especially him because he was quite unstable. And again, this will be the time where the anaesthesia team will do their blocks, which will be like intercostal blocks using ultrasound guide. Sometimes the surgeons will also do ones where they'll do it in surgery, do a splash block as well. Once we have finished clipping and prepping and doing all the bits and bobs that we need to in prep, we'll move them through to theatre. When we position, it's a little bit similar to this. Their bum is normally in a trough, which you'll probably use in practice for your x-rays. Their forelimbs are tied forwards. Bear huggers are normally shoved underneath their bums, and as much over the head as possible that's not obviously interfering with the surgical site. And then we use ChloraPrep wands, which I don't know if you guys, I'm out of practice, a small opinion. I don't know if you guys use that in first opinion. You do? Great. They're handy little things to have. And yeah, we kind of do that. And then the clinician will come in and drape the patient. Then I'm going to talk a bit about equipment. Again, do you guys have electrical cautery and stuff like that in practice? All happy using it? All know kind of how it works? We use this predominantly in all of our surgical cases. We've got monopolar, bipolar. Majority of the time we're using bipolar. Monopolar is for orthopaedics a lot of the time. Some clinicians like to use it in soft tissue as well. It's obviously electrical currents that's going through to help cut and cauterise. So you get a lot of charring and things like that. So we, some of the surgeons don't like using that in thoracic surgery because it just prevents healing and things like that. And then the other cool machine that we've got is a Gen 11 machine. Any of you guys seen this before? Yeah? So we've got two types of devices, or we have three types of devices. We've got harmonic shears, which are up at the top here, and then we've got a harmonic scalpel. We use these in thoracic surgeries quite often. The other thing that we've got as well, which is an end seal, which is similar to like your Ligashore and stuff like that for lap procedures. We predominantly, as I say, use a scalpel. Unfortunately, nowadays they're actually not producing them anymore, so we're trying to find an alternative for this. This machine itself is ultrasonic. sound waves that causes friction, and that's how it cuts and cauterizes vessels in surgery. The shears has got a stationary plate, and then the blade itself oscillates at like 55,000 RPM per second, and that's how that cauterizes and cuts as well. Really handy bits of equipment that we have. It prevents a lot of blood loss. If you've not seen them in use, they are great. When you make a surgical incision, it almost cauterizes straight away. There's hardly any blood loss, whereas you'd have a little bit more with the monopolar and bipolar forceps and things like that. So they're quite handy bits of equipment we have. And then a little bit about TA staplers. Any of you guys seen these? Use them? Know what they are? So these are what we use for thoracic surgeries they're thoracic abdominal instruments. So they're used for lung lobectomies, splenectomies, abdominal resections of guts and things like that. They come in all shapes and sizes. We've got a mixture of the echelon version as well as the DST. I just put an image up of all three. So we've got one up the top here on the top right, which is the 30V, which is a vascular one. The bottom one is just a standard 30. We get them in 60 as well, and you can get them in 90s. And then there's the DST on the other side. So, and that's a 90, it's one of the biggest ones you can get. The difference between them is the 30V is a vascular one, so it means that the compression of tissue is up to about 1 millimetre, whereas the standard 30 and 60s and 90s are about 2 millimetre. So it means you get a better contraction of muscle and tissue, and you're less likely to get bleeds and things like that. Also, the 30V has 3 rows of staples rather than 2. They're all titanium staples as well. So this is kind of what we used when we were doing chunk surgery as well. So that's just a bit about them. And then, really sorry, there's going to be some gruesome pictures, so hopefully nobody's too concerned about them. So this is the surgery itself. So we did a standard approach for thoracic surgery. We've obviously opened up the breastbone using the cleaver and oscillating saw. Obviously really important with this surgery that you constantly flush the blade because it gets hot, cause friction burns and things like that. So yeah, we open the chest up. So 3 reasons really why we do median sternotomy. Obviously in Chunk's case there was concern there was a bulla, and obviously Nichole's just discussed that anyway. It's an air-filled sac which can cause a spontaneous pneumothorax. Normally found in deep-chested large breed dogs. Other things that we open chest up for are medium sternal masses. We do that for them because it's just easier to get around the whole lung and also look around the whole mass, easy access. And then obviously another reason for opening chunk up was potentially a pythorax as well, and that could be foreign body or unknown origin. But the problem being with the deep-chested dogs doing median sternotomy is it's really hard to visualise the dorsal aspect of the lung. So back to chunk and what we did a standard midline approach on sternum. We used the harmonic scalpel. We obviously you can see we've used rib spreaders here and gained access to both lung lobes. This far left image, you can see there's a small bulla. Technically not his image, but it was just wanted to kind of show you guys what it can look like once we've opened it up. So yeah, with chunk we found generalised swelling, pleuritis, ventral mediastinum thickening, which the surgeon debrided with the harmonic shears to allow better inflation of the lungs. There was left cranial lung lobe adhesion and left thoracic wall thickening. We did actually perform a right lung lobectomy on him, which I've got some images on the next slide. So you can see this is just an example of what we actually did. There was part of his lung lobe that was abnormal and we obviously removed, but this is just showing one with the bulla, just easy to see. You can see this TA stapler in use, which is quite cool. You can see it clamps down. firing pins in and the staples in, and then just a scalpel blade used to cut the tissue away. And you can see then, this is kind of what it leaves you with a line of staples. Sometimes you can get some slight oozing from each corner, which you can use PDS or Vicryl or monocryl just to close over those areas. A bit more close-up image of what they look like. And then these are just lateral approaches that we've done as well in the past for bullers. You can see they're quite big as well. So just some gory images because I like that sort of thing. And then closure-wise, this can be many different techniques. Back in the day, it was serpage wire, which is a bit traumatic to the animals. It can cause a bit of interference. It cause increased risk of infection and things like that. We now tend to use, in big breed dogs, we'll use leader lines, which are normally what you'd use for lateral suture with crimps. If they're smaller breed dogs, you can use PDS, your big PDS, your 1s and 0s, to help close. The importance with this is that you're pulling these quite tight and holding them. You can use gallo bands to hold sutures in place if need be, but we're using crimps, which are little metal things that you slide along the sutures, and you can see here we're just crimping down in 3 places, like what you would do with a lateral suture.
So just a few things to think about on recovery. So we just need to get a pain plan from our clinician. So that might be that he continues on his CRI. It may be that we put him up for opioids, Q4, Q6. And then for him especially, he did need oxygen supplementation. I'll get onto that in a minute, but we did try and wean him off the oxygen before we moved him back to ICU, but he did struggle a little bit. So we called ahead to ICU and let them know that he did need to stay on oxygen, at least for a little while. And then the aim at the end of all of our surgeries is to achieve extubation. Specifically with him, we wanted to be able to wean him from the ventilator. He'd been on the ventilator for more than 24 hours at this point. So we wanted him to be able to spontaneously breathe by himself, which we did achieve. He managed well without ventilation, without a ET tube, but he did need some supplementary oxygen. A standard monitoring that we would do of your blood pressure, he still had his arterial line in, so he had invasive blood pressure monitored in the post-operative period. Standard heart rate monitoring, temperature, he was pyrexic beforehand with the pyothorax, and SpO2, knowing that he was hypoxemia at some point, we always say to keep an eye on that as well. Then we would hand over to ICU our plan, what our surgeon would like. So he had chest drains placed, they need to be drained. Any specifics that our surgeons want, anything checking, particular medication, non-steroidals. And then we update our treatment sheet, which is, we have online Instinct. So we put everything on there that we want. And then ICU may make changes, they have their own clinicians dependent on his progress and things like that. So Chunk had a long recovery in the hospital. He had a lot of complications along the way, but we are pleased to say he's doing very well. He's at home, he's been discharged. This is a picture of him in his kennel a few days later, obviously feeling much better than he was pre-surgery.